What's going on, buddy? Hey, how you guys doing? A little late. Literally just got done recording a podcast for like the last hour, so that's why I'm like 10 minutes late. But hopefully that podcast will be out. Dr. Goals, you guys go check them out. Go follow them. Hopefully it'll be out a couple weeks. Talking about radiology, talking about life. Austin, what's going on, man? Thanks for the thumbs up. How have you guys been? You got my case of the day for today. A lot of you guys were right on the money as far as the owl part, right? I don't know if I got enough W's in that last one. But you guys were on the money for the owl part. There was something obviously wrong with it. And then it got a little iffy as far as which way was the something wrong. So we're dealing with the shoulder, okay? So for anybody who wasn't clear about what body part or what anatomical... sorry, I'm going to put this water cap on. All right. Missed your lives. I'm back. So this is the shoulder, right? We're talking about the shoulder. So something's going on with it. This is the humeral head, right? The neck here. Sorry, neck here. This is the humeral head. And it shouldn't be sitting here. It should be sitting here, right? So we know something's going on with the shoulder. The question is which way is this something going on with the shoulder? And this one is has a lot of different implications to know which way is the good way or which way is the really bad way. It shouldn't be good way, but which way is the bad way and which way is the really bad way. So this was an anterior-inferior dislocation or an anterior dislocation. You can kind of call it that. I don't want to say inferior per se, like not just an inferior dislocation because that has a whole different aspect of it. But this is an anterior dislocation. Does anybody know what types of other fractures can be seen with an anterior dislocation like this? Give a couple of seconds for that. Anybody? Froz, what's going on, man? So, anterior dislocation. Anybody? Hill-Sachs, Bankart? So those are the types of fractures that can be seen with this. I don't want you to just flat out say no Bankart lesion on radiography on these X-rays. You can't just say there's just no Bankart lesion, okay? Bankarts, you can say there's no osseous Bankart lesion. Professor, no, far from it. You can say there's no osseous Bankart lesion because there's different types of non-osseous Bankart lesions. So there's kind of a semantics issue, is that if you say no Bankart appreciated on the X-ray, well, you know what? There may be a non-osseous Bankart. If anybody wants to go look them up, it's like alphabet soup. There's like 6, 7, 8 different ones. Go to Radiopedia. They have a really good explanation of all of them. There's different types. It involves different types of the humeral head. Of the glenoid. So go look them up, basically. So the osseous Bankart is what everybody refers to when they're talking about these shoulders dislocations, and they say there's no Bankart lesion. That's what they're referring to. And then Hill-Sachs that's what you're going to see on top of the humeral head. These are seen really well with MRI. Yes, you can see it with CT as well because it's osseous, but if they're non-osseous lesions, like these Bankarts, if you get an MRI, you can really characterize what types of non-osseous Bankart lesions are on the shoulder. So this is an anterior-inferior dislocation. This is very common, happens a lot. People can be susceptible to this depending on their anatomy, depending on underlying congenital issues. So this is not the worst one to have. For USMLE Step 1, when I say posterior dislocation, you're going to tell me two things. What are they? Anybody? Going fast. Anybody just joined? I just recorded a podcast with Dr. Goals. Go follow them, please. She's doing, Dr. Trot, she's doing some amazing stuff. That podcast should be out in a couple weeks. Seizure, Carolyn said seizure. That's one of them, definitely. So posterior dislocation, the first clue, USMLE Step 1, they're going to say seizure. What's the second one that they love to talk about? Which I've never seen one. I'm waiting to see somebody have this. Electrocution. Electrocution is number 2. So anytime you hear those two things, you're thinking about a posterior dislocation. Now remember, when you're looking at a posterior or a film like this for a shoulder, and it looks normal, be careful because one view is oftentimes no view, right? If you just have one view and you're like normal next, but then the ED is like, no, he's really complaining about shoulder pain. Then be like, well, do you mind ordering like a couple other views? So you can do internal rotation, external rotation, scapular Y views, axillary views. So you have a bunch of different types of views. And the main thing that I want to point out is that a posterior dislocation on this one view can look completely normal. It can be very subtle. But once you get other views, then you're like, no, something's going on. So if you have an internal rotation and an external rotation, that should rotate normally, right? But if your tech labeled internal rotation and external rotation and nothing's happening to this and it's kind of just sitting there, well, then be very careful about a posterior dislocation. And then you do a scapular Y view or you do an axillary view and you notice that humeral head is actually posteriorly displaced. So think about that. What is an inferior dislocation? What's the one thing? It's rare. It's like 1% of the time. It doesn't happen that often. But inferior dislocation for step 1 and for radiology boards, what's the one thing that you need to know about this? Anybody? Posterior dislocations, the patient's going to come in, and I've called one of these, and I wasn't confident on the call because I was like a second-year resident when it was happening, and I was like, I think it's an inferior dislocation. So I called up the ED, and I was like, yo, hey, do you mind checking his physical exam? And can he not put his arm down from this position? Inferior dislocations, they'll come in with their arms up like this, okay? And they can't put it down. So the X-ray was actually taken like this, and the tech was like, I had a hard time positioning his arm. And it was because it was an inferior dislocation. There's a fancy word to it. If anybody wants to shout that out, kudos to you, or else I'm going to say it in a couple of seconds before going to my next tangent. The other thing that I want to point out, please, please, please do not get confused with shoulder dislocations and AC joint injuries. Those are two different things. Yes, they can happen like at the same time because of some sort of mechanism, but those are two different things, okay? AC joint injury is up here. It's up here. Shoulder dislocation is up here. That's when the clavicle is not aligned. This is not a good view for it, so I can't really show you what it should look like. But an AC joint separation or injury or strain, whatever terminology you want to use, you're going to see the clavicle end here, and then this is actually going to be raised up. It's going to be higher. And then you can get to, perfect, somebody mentioned it, luxatio recta. Thank you, nailed it. So there's different types. Go look up the Rockwood classification, and they usually go higher and higher and higher, but actually at one point it actually goes lower, and then it's going to get stuck down here. So remember that AC joint injury is not a shoulder dislocation. That's the main thing that I want to stress because that's commonly confused and it's commonly kind of said together. Anything else about this case? You guys all did a really good job on today's case. Was it too easy? Should I have done something a little harder for you guys? Or you guys are just that smart, right? I know you. You guys are that smart. I don't think there's anything else with this. Always look at the soft tissues, by the way. Oh, yeah. Let's talk about that. Always look at the soft tissues, okay? You can tell a lot of stuff from the soft tissues. You can have hematomas in there. You can look at the space, the widening between the humeral head and say the clavicle or the acromion and say if it's wide. Maybe there's some sort of fluid buildup in there, so remember that. And then I want you to think about, what was the other thing? I just had a train of thought. Come on, man. What the hell was it? Look at the soft tissues. I'm going to stall while you guys ask me questions. You need chest. Like what? To work out with? To what? You want more chest x-rays, you're saying? That's what I was... See? I stalled. What happens to the humeral head with a chronic rotator cuff injury? Anybody? Does the humeral head chronically now sit higher or chronically sit lower with a rotator cuff injury? And does anybody remember what the rotator cuff muscles are? Yeah, I'll get you more chest x-rays. Don't worry. I have an abundance of chest x-rays. So anybody joining, the question was, what happens to the humeral head? Somebody mentioned lower. How about somebody mention the opposite of lower? It's going to be higher. So on a chronic rotator cuff injury, the humeral head is going to be sitting higher than it should, right? Because the rotator cuff wants to kind of do one of these and pull everything inside, right? And when these are all jacked up, stuff's not working, your deltoid actually pulls that thing up, all right? So you have a high riding humeral head. You'll see that in my reports, is that you have a high riding humeral head, and that's suggestive of a chronic rotator cuff injury. You do the MRI, and you may see one of the rotator cuff muscles that's messed up, sprained, strained, torn, whatever it is, right? Anybody remember the sits muscles? SITS. Those are your rotator cuff muscles. What else you guys got for me? Nada? Nada? How many ways can I say nothing? English, nothing. Spanish, nada. Punjabi, kuch nahi. What else? Anybody? What other language do you guys know? You guys know so many languages. It's cool. I wish I could learn like a bunch of different languages. Supraspinatus, infraspinatus, subscapularis, and teres minor. There you go. So remember, niente. I like that. What language is that? Teres minor. You guys remember that. It's not teres major. Teres minor. That's subscapularis should be. Supraspinatus, infraspinatus, subscapularis, teres minor. All right, we good with today's case of the day? Again, I just did a podcast for the last like hour and a half. Go check out Dr. Goals. Go follow Dr. Trot. Sorry, she's absolutely amazing with what she's doing. When do you want IV contrast and chest CTs? Well, that's a good question. The main reason why I would not want it, let's say that, is if you're just checking for pneumonia. If you are checking for a pneumothorax, I don't need contrast for that. I can see a pneumothorax without contrast. Are you checking for an empyema? Yeah, contrast would help because, oh yeah, that's a good one. What do you see for an empyema on a chest x-ray, a contrast-enhanced chest x-ray? What's the radiologic sign or what's the sign? Anybody? Can you do a CTPA? Like, yeah, for a PE study, for case of the day? Absolutely, that's everybody's favorite study. What was the other question? What else? Oh, IV contrast for what else? Malignancy, yes. You mentioned air fluid level. No, you can't see an air fluid level in empyema, sure, but it's the split pleura sign. Pleura. If somebody just go look it up. I wish I had a good example of it right now. But split pleura. That's what you'll see for an empyema on a chest CT, a contrast enhanced chest CT. When you see that, it's going to be an empyema. Otherwise, yeah, if you can give contrast, hey, please do it. And there's a difference, by the way, guys, for a CT with contrast in a CT-PE study. There is a big difference. The timing of it's completely different. A PE study is timed for the contrast to be in the pulmonary arteries. A CT with contrast is completely different timing. So really figure out what you want. Do you want a PE study or do you want just contrast on board? Do I read coronary CTAs? I have. I'm not specialized in it. It's not something I do regularly, but I've done rotations throughout residency that, yeah, we've read coronary CTAs. Yep. All right. That was a good one, right? Real quick, you guys, again, did some good stuff. Oh, how to tell? Man, that's a tough question. How to tell ILD on a chest x-ray? You have to read so many chest x-rays. When you look at an ILD, and God, there's so many different types of interstitial lung disease. I'm not getting into that right now. There's so many different types. They're all different based upon CT characteristics. There's different like honeycombing, ground glass, architectural distortion, a bunch of different stuff. Off a chest x-ray, it can be very tough though. You can look at a chest x-ray, you may think that it's completely normal, but then you do a CT scan and then it's actually some sort of interstitial lung disease. By the way, anybody have heard of the word high resolution chest CT? High resolution chest CT, yes, it's high resolution. And but at least in our institution, pretty much everywhere else, you basically get the patient prone, and then you do them supine, and then you do expiration, inspiration. You do a bunch of different variations, and you keep taking CT scans. And basically, you want to see stuff like, hey, if that patient was supine, was that stuff on the bottom atelectasis? And then when you prone the patient, did it open up? When they took a big deep breath in versus when they blew the breath out, was there any air trapping? Air trapping can be seen when you do that, and that's a sign suggestive of some sort of underlying lung issue. Whew, good questions. Got into the do them a lot. Nice. That radiation. Yeah, but when you do a lung screening chest CT, the dose is very low. Especially, so these ILD ones, yeah, they're a lot lower than a high dose regular chest CT. And then when you do like a pulmonary nodule follow up or something like that, oh, those doses are so low. And why are they low? Because think about it, the lungs are just a bag of gas. So you don't need a lot of radiation to go through these lungs, not at all. But if you needed some radiation to go through the liver, the kidneys, the fat down there, yeah, then you're going to need more. So that's why these lung screening chest CTs are very, very low dose. And I'm talking like sometimes the DOP is like 80, so low. All right, that's a good one today, guys. Quick and short. That's not the word, quick and sweet. I'll pick one up. Oh, I'm on call starting tomorrow for a week straight, and I'll let you guys know if there's anything good coming in. We'll continue this. Don't worry. I got you. Until next time, you know how it is. Later.